Michael Danziger, and your arteries are on fire. At least you better hope they're not. The bad news is that most people with cardiovascular disease or peripheral arterial disease have ongoing, daily progressive damage to their arteries. We call this arteries on fire. Unfortunately, you can't feel the fire burning, but if you could feel the burn, it would definitely grab your attention. The good news is you can put out the fire by understanding and eliminating all the different causes of ongoing arterial damage and allow your arteries to heal. During this presentation, I'm going to highlight or blame 10 potential causes of artery damage. Almost nobody has all 10 going on, but almost nobody has 0 either. Most of us have some or most of these issues fueling ongoing damage in our arteries right now as we speak or on a daily basis, and each can be minimized or even eliminated. These reversible causes all cause artery inflammation. Now let's talk about what's putting the flame in inflammation. I'm talking about tobacco and toxins, junk food, high blood pressure, dyslipidemia or cholesterol issues, high blood sugar, obesity, underactivity, emotional stress, gut microbes, and genetics. I'm going to spend the rest of this presentation talking about each of these. These 10 are not the only things fueling the fire, but they're all key issues that are worthy of our full attention. Starting with tobacco and toxins. The worst thing you can do to your arteries is smoke. Cigarettes and tobacco are loaded with toxins that damage the arteries. It's easy to make the connection between smoking and fire in your arteries. If you still smoke, you've probably tried to quit because you know it damages your arteries, heart, and lungs. Please get help. Tobacco and toxins are also in secondhand smoke, which damages the arteries. Did you know that other toxins can damage arteries? Too much alcohol, recreational drugs, and the cumulative effects of chemicals in highly processed foods and beverages can all potentially contribute to fire in the arteries. Even air pollution has a damaging effect on your arteries. Junk food. We're talking about food products made in factories that have long lists of ingredients. Highly processed foods that do not exist in nature and did not exist 100 years ago. There are thousands of these food products in stores and restaurants, and they're designed and manufactured specifically to make you love them, crave them, and keep buying and eating them. Your body thrives on natural food, not junk food or unhealthy fast food. It's not surprising that those unnatural foods damage the arteries and fuel the fire in them. Not only are those foods bad for your body, every time you eat them, you're missing out on the opportunity to eat healthy foods that heal your arteries. Don't let junk food and unhealthy treats replace healthy food. Next is high blood pressure. A healthy blood pressure is around 120/70 or less. Even 130/80 is okay, but any higher fuels the fire in your arteries. High blood pressure has many causes, but the main ones you can affect are related to food choices, exercise, body weight, and emotional stress. Healthy arteries are relaxed and flexible. Unhealthy arteries are tense and stiff, which forces your heart to work harder to pump blood, resulting in high blood pressure. The high pressure in the arteries causes damage to the artery lining. Next is dyslipidemia. When the fats in your blood are out of balance, we call this dyslipidemia. Having high cholesterol, or too much bad cholesterol, or not enough good cholesterol, or high triglycerides are just some of the different forms of dyslipidemia people talk about. There are many different types of fats or lipids and lipid particles that carry fats in the blood. Certain lipids and lipid particles damage your arteries and fuel the fire inside them. The worse the cholesterol issue, the faster it builds up inside the artery wall, leading to blockages and reduced circulation. Work with your healthcare team to aggressively manage your blood lipids and lipid particles. The right eating, exercise, medication, and supplement strategy are crucially important to minimize and damaging the effects of dyslipidemia or unbalanced fats in your blood. Next is high blood sugar. Everybody has sugar in their blood to provide energy to the organs and tissues. However, if the sugar level gets too high, it causes all sorts of havoc within the arteries. Your arteries are on fire if your blood sugar level is too high. This is especially true for people living with diabetes that is not well controlled. High blood sugar directly damages the proteins in the artery lining and slows the healing of artery damage. In a way, high blood sugar is like a toxin to your arteries. Some people like to imagine the sugar is like microscopic glass shards damaging the arteries. Even if you don't have diabetes, you may have pre-diabetes, which is a milder form of high blood sugar. In either case, eating the wrong meal is like throwing gasoline on a fire. Obesity. Excess body fat, especially in the abdominal cavity, fuels the fire in your arteries. Unhealthy fat accumulates inside the liver and muscles, leading to dyslipidemia, high blood pressure, and prediabetes or diabetes. A fatty liver, also known as non-alcoholic fatty liver disease, leads to all sorts of chemical imbalances inside the body that collectively damage and inflame the artery lining and heart. Have you ever heard the term metabolic syndrome? This is a common condition with a combination of the risk factors discussed earlier, usually linked to obesity. Reducing your daily calorie intake and increasing your physical activity on a permanent basis are the keys to preventing or minimizing the damaging effect of obesity. All body sizes are beautiful, but if you're struggling to lose excess body fat to improve your health, please seek help. The external accountability, structure, and other benefits of a health coach or formal weight loss program can mean the difference between long-term success or not. Underactivity. Your muscles, heart, arteries, and the rest of your body are begging for you to exercise daily and be active. Unfortunately, you can't hear or feel them pleading with you to do so. Increasing your exercise, including gradually increasing your walking, would make a favorable difference in your artery health. Exercise stimulates the blood vessels and blood flow in multiple positive ways. A combination of cardiovascular type exercise, resistance type exercise, and flexibility balance exercise is ideal. Stress. Emotional stress generates stress hormones that stress out your arteries. Arteries have a layer of muscle running along their length, and stress hormones cause that muscle layer to tighten. This temporarily makes the arteries tighter, stiffer, and less flexible, causing blood pressure to temporarily increase. Deadlines, traffic jams, negative people, disappointment, anger, upsetting news, and a whole range of negative stressors have the potential to burn up your arteries by triggering your stress hormones. Minimizing the effect of chronic daily stress is all about avoiding situations that trigger it and practicing positive attitude, which is a skill that benefits from daily intentional practice. You can't always affect what happens to you, but you can affect the way you react to it. Studies show that negative attitude fuels arterial damage, while positive attitude helps minimize it. Gut microbes. Your large intestine is loaded with helpful bacteria and other microbes that eat what you feed them. They love vegetables, fruit, and fiber. The wider the range of plant material you eat, the healthier and happier your gut bacteria are. When you feed them junk food, it fuels a bad cycle. The bacteria turn unhealthy food into unhealthy chemicals that get absorbed into your blood and damage the arteries. An overall unhealthy diet also reduces the types of healthy bacteria and increases the types of unhealthy bacteria in your gut. The science is still emerging, but there's no question that part of the favorable and unfavorable health effects of food is related to the gut microbes. Don't forget, they eat what you feed them, so be kind to those little fellas. Genetics. We know that some people are at a higher risk of cardiovascular disease than others because of the genes they inherited from their parents. However, studies show that most of the risk for artery problems results from the things you can control rather than your genes. The higher your genetic risk of cardiovascular disease, the greater the payoff resulting from aggressive management of the factors you can control. Your genes are not your destiny, and we know that healthy habits favorably affect the way our genes are expressed. Also, knowing your specific genes can often provide valuable information for doctors to help make specific recommendations about food, supplements, and medications to help manage and minimize the risk of cardiovascular disease. In summary, most people with cardiovascular disease, including peripheral artery disease, have a tremendous opportunity to improve several different issues that continue to harm their arteries on a daily basis. The number of unsolved issues has a lot to do with how hot and fierce the fire is burning. On the other hand, if you can make progress on every issue that needs work, then you can put that fire out and let your arteries gradually heal over time. Work with your healthcare team to discuss and protect yourself from each of these potential sources of internal damage. Thank you for the opportunity to present this information today.
I know the topic is diabetes, but we have to redefine and really look at diabetes in a different way. And it's about behavior. And we're going to talk a lot about feelings today. You know, diabetes, everybody knows, is a disease that involves a loss of sensation, but there's much more to the loss of sensation than the physical component. And I know a lot of you have heard me speak before about the biopsychosocial or psychospiritual component of chronic disease, but that's really what diabetes is about, especially because it is a monster that we have created through processed living. So we're going to go over human behavior, we're going to go over feelings, we're going to go over what processed living really is, and then we'll kind of build the story up into the disease that we're all familiar with. But we need to get comfortable with the unfamiliar aspect of this disease, understanding where it came from, how we created it, and how we really breeded this monster that we're dealing with right now. So diabetes has been largely ignored in the medical field, specifically in cardiovascular trials. So the first point I want to make, and by the way, this talk is going to be conversational and anybody can interrupt at any time, no problem. Diabetes is a vascular disease. That's one thing that we have to reorient and understand. And it's a vascular disease that traditionally has been omitted from cardiovascular teaching and trials. Literally, it has been excluded in the beginning because it throws everything off. It just mucks up data, it mucks up numbers, and it doesn't allow a hyper-focused look at bringing medications into the market, devices, because it's too confusing and it affects literally every body process. So diabetics have been disenfranchised from data for over 50 years. So the implications of that is that we have to relook at what the role of diabetes has really played over the past 100 to 150 years in a world that has been more collectively westernized. What do I mean by that? The number one risk factor for every problem that is fueling chronic disease in this country and around the world, and this country takes the lead by far, is diabetes. So if we plug diabetes back in to re-looking at medicine, what we find is that insulin resistance, which is the true problem, is at the root cause of over 80% of cardiovascular disease. Literally, the way you can look at that as a dipstick is if you go to any hospital and you find out why people are admitted in a hospital, every disease process almost is related to diabetes. But it's not the number one reason that we look at as to why they're there. Why is that? It's because, again, diabetes has been disconnected from other disease processes, mainly chronic diseases. And also, the insulin resistance component has been ignored. And if we go back over 100 years, what we'll find out is that as diabetes used to be a disease of coma, because before treatment of diabetes, there was no way of taking care of kids that were developing diabetes and they just died. The next phase of diabetes in this country was managing the chronic complications of diabetes after we discovered insulin. So we shifted from having no cure. Literally, if you were a diabetic and admitted in a hospital over 100 years ago, you were given a regimen of olive oil, bacon, protein, just to wake up the brain from the negative consequences of the hyperglycemia. And they died. And the minute insulin was discovered, we were literally rolling kids out of the morgue. And there are pictures of this. I'm just not going to show them because they're pretty horrific, but they look like the Holocaust. Emaciated young children, weighing kilos, being rolled out of the morgue after being administered insulin. So after 1922, when we discovered the ability to harness insulin, people now had a new second chance at life. And the problem was that just like when presented any quick cure, we come at a disease of choice and behavior. And so what do I mean by that? The ability to have insulin to correct acutely diabetes, which is a problem with either not producing insulin or resistance to insulin, which we created, was that people said, well, now I can just take insulin, live life the way I want to, and do whatever I want. And so what that allows is diabetes to take its insulin resistance, the type 2 diabetes that we're all dealing with and talking about today. It allows it to continue to grow slowly like a cancer that you never knew you had. And then you get to see what it really does. And it affects every body system head to toe. And the one that we're specifically related to here today is peripheral artery disease, which diabetes fuels most of around the world. And so most of the speakers you're listening to today deal with a disease process called critical limb ischemia, which leads to amputation. And what that literally does is it severs a body part from the whole body. But that's exactly what diabetes does, is it starts to sever pieces of the body from the body. It starts to sever the person from their community, literally being isolated off with chronic diseases, not being able to walk, going blind, and being on dialysis. So I'm trying to build up a pattern for you so you can see what diabetes does. It causes a person not to feel. And the inability to feel is not just on the physical component, which leads to the foot deformities, which when combined with the peripheral artery disease, which diabetes accelerates because diabetes is a vascular disease, but losing the ability to feel physically, losing the ability to feel your body, and losing the connection from the community, from being amputated and having multiple chronic diseases, causes this massive problem of not being able to self-identify. People literally shut down because of this disease process and literally cannot connect with themselves. And so using diabetes as a great analogy or metaphor for a lot of things that are going on in the world, it's a fascinating disease process that allows us to understand what a biopsychosocial model of looking at chronic diseases can do when we start to understand that these are mostly diseases of human behavior. So diseases of human behavior involve a 3-part cycle. They involve feelings, they involve thoughts, and they involve behaviors. That's why being educated, just like you are today, learning about the root causes, what the treatments are, what can be improved. If we start to educate our thoughts, then we can change behaviors. And if our behaviors change, we start to feel better. But if we intercept this cycle from feelings, if we address the fact that, hey, diabetes causes me to not be in touch with my body because I can't feel, because I have too much sugar in my body, then we can start to understand what the root cause is. And what it is hyper processing of life. So when we hyper process food, we remove meaning out of food, which means we no longer have anything that's nutritious. When we hyper process our lives, and think about what COVID has done to us, when life is hyper processed, we lose all meaning of psychosocial interaction. People lose connectedness. And when we have a hyper processed sense of self, when we're on autopilot, we forget who we are. And that's exactly what diabetes does to the body. It insidiously, slowly causes us to lose sensation by attacking the nerves, just like you heard in the previous talk. So if your nerves are on fire, that's one spectrum. They're short circuiting, right? People have what you typically think of as neuropathy. But if people lose sensation, then they have a disconnection from their body, which literally can lead to amputation. So critical limb ischemia is the end stage of peripheral artery disease. But there's also much more to what that represents. It represents critical life ischemia, and it also represents something that I call critical love ischemia. Essentially, it's the inability to separate what's going on from the patient from the disease process. So diabetes starts to overtake the identity of the person. Think about this. Diabetes is the #1 cause of blindness, dialysis, and amputation in this country. Imagine what living life as a blind, end-stage renal disease patient with amputation looks like. It's hard to look past that person in a wheelchair with one leg who's on dialysis as diabetes defining their entire life. And guess what? It happens. So how do you tease out the human being from there? Well, there's another big problem that happens, is that healing is replaced by healthcare. Living is replaced by a processed life, and profit is replaced over people. And that is my analogy for what processed healthcare and living does, which diabetes fuels, right? We can think of processed life in terms of food. That's easy because we take everything that's nutritious out of food and we put it in a box and we sell it to people. And that fuels insulin resistance. So by allowing us to process sugar over 100 years ago, we created the #1 addiction the world has ever seen to sugar, which literally has hijacked our taste buds. And anybody that has kids sees how fast that happens. So hyperprocessing food is related to behavior. And that's why it's so important to educate people on what the root source cause of the #1 risk factor for cardiovascular disease, which is insulin resistance. So now we have a problem of health scare instead of being able to provide people with health care. And what the cause of that has created is diabetes. So the world is literally getting heavier, okay, with an affinity for carbohydrates that we've never seen before, because processed carbohydrates don't exist in nature. Now, man is so genius to not only take processed carbohydrates, but to combine them with what you heard before, bad fats, which also do not exist in nature. And that is the most addictive substance that man has ever created, more than cocaine, you know? So think about what neon lights, you drive by on a highway, a Krispy Kreme. That combination of fat and processed sugar doesn't exist in nature. So we weren't designed for that. And the body interprets that as an energy source correctly, which we store, which fuels insulin resistance, which creates this pandemic of diabetes. So really, the #1 risk factor for PAD is diabetes, and diabetes is fueled by human behavior. And that human behavior severs us from our body, it severs us from the community, and it severs us from ourself. And that is something that healthcare needs to address if patients are to have proper healing instead of whatever we call this mess that we're in now. So many of us are dealing with the end stage of that, which is why we relate PAD and CLI so much to cancer, but the patients never know that they're dealing with it until they're given that diagnosis, which is why it's so scary. And so I want to end it by applauding the organization for raising awareness for this disease process. I think I'm attached to it, but it's the best example we have of just how much chronic disease severs us from the self, the community, and our identity. Thank you so much, Kim. I really appreciate being able to be here and talk with you guys, and I'll take any questions.
Thank you. We have Douglas, who is asking about the most successful diets you have seen your patients on.
So that's a great question. I don't like the word diet, but we'll use it for what it is. I think the best behavior modification strategy has to be tailored just like a prescription. So I literally take paper prescriptions, which don't have any meaning right now because it's all electronic, but I write it there so the patient understands. The most important thing they can leave with is information and education. It is not a prescription. And so it's tailored to the patient's body type, their physique, and their level of insulin resistance. For people that are endomorphs, who have an affinity to build truncal obesity, which automatically means insulin resistance, they have to go on some type of, for lack of a better word, a keto-like lifestyle to jumpstart insulin sensitivity. And our practice, we are geared towards taking people off medicines, not prescribing medicines. And I think that's really the measure of what a healing type healthcare practice should look like, if they allow patients to take control back of their own bodies in healthcare, not being subscribed to pills and being told what to do by physicians. So the number one thing is whatever it allows them to regain insulin sensitivity. And it's no different than what was done before insulin was discovered. Literally, when people were admitted, they were given healthy oils, healthy fats, healthy proteins to be able to bring down the sugar levels. And then they were given education. They weren't sent home from the hospital. They were actually admitted into cottages and little homes and taught as a community before being discharged back into the wild.
I think we should do that again. We have Monique that is here with a question. Monique, go ahead and unmute and ask Dr. Michael your question.
I have a question about apolipoprotein. What happens to it in diabetes, and why is it tested all the time by my internist?
So one of the best markers, inflammatory and lipid markers for cardiovascular disease is lipo-A. But the interesting thing is that if you look at what systems diabetes affects, so it's a vascular disease, therefore it's going to also interfere with every metabolic organ in the body. So if you look at the pancreas, the stomach, and the liver as a triad, okay, diabetes will affect the ability for the liver to process lipids because it is in a mode of storing energy. And if it's in a mode of storing energy, then the body doesn't understand that it needs to be able to break down fats and proteins to be able to create all the healthy carbohydrates that you need. So a marker of that relationship being inverted, which is also related to directly proportional to inflammation and also insulin sensitivity, is that marker. So that's why cardiologists are interested in it. The problem is, what do cardiologists want to immediately do is start prescribing people statins and anti-inflammatory medications. But really what needs to be targeted in conjunction with that is the behavior modification for the patient to increase their own insulin sensitivity. Does that make sense?
Oh, yeah. Mine was really low, though, like 0.61.
Mm-hmm. Well, that has to be looked at in conjunction with the rest of your labs with your doctor. But I'm trying to give you what the gist of that is inflammatory markers and lipid markers that are markers for more disease to come. But I want you to look at it this way. Forget what your numbers are. Look at where you need to be and what you need to do, and those markers will come down as a trend. Triglycerides should come down. HDL should go up, okay? And the LDL should be at a healthy state. In the 80s, there was this problem called the cholesterol mafia, fueled by the statin business, which shifted people's awareness away from decreasing insulin resistance and to jumping on the prescription boat. And that caused a lot of people to subscribe to low-fat diets, which is totally wrong, against nature. It's not the way our bodies are designed. Healthy fats are good for us. Healthy proteins are good for us. There's no totalitarian diet that is right. And think about what we've been fighting about for forever in this country that societies and people can't agree on. It's what to put in our mouths. But if you were to show all this food to animals, they wouldn't even sniff it. They'd walk right away. I mean, you guys are talking about pets or something for pad. Think about how animals look at food. You put a bunch of options in front of them, they automatically go to what's right for them. But we have this paradox of choice that confuses us. And really what we need is a whole foods diet not whole foods, but a whole foods diet, which is eliminating the processed human behavior out of the decision-making tree to allow our body to recalibrate so that the pancreas, the liver, and the stomach can function the way they're meant, instead of constantly being in this energy storing mode, which we're very efficient at.
And we have Anna who has a question. Anna, go ahead and unmute and you can ask your question of Dr. Michael.
Okay, thank you, Kim. Hi, Paul.
Right.
Is there a either a direct or indirect correlation between insulin resistance and panic anxiety disorder?
Yes, there is. So insulin resistance can fuel so many things, not just in the cerebral vasculature, but it also affects a completely different system, which is the autonomic nervous system. And that system is it should be hyper-tuned so that a human being can able to acknowledge their feelings, which then affects their thoughts, okay, which allows them to act or behave in a certain way. If the feelings component is dampened because of dysregulation of the autonomic nervous system, which diabetes is so good at, then patients may have no awareness or have a lower awareness of their fight or flight response, okay, and their stress response. So a patient may be stressed and not know it. You can thank diabetes for that. A patient may be overwhelmed, okay, their neuroendocrine circuit may be on fire and they may not feel it, okay? So that's why the first notable feature of hypoglycemia to a patient could be literally passing out, sweating, whereas somebody who is in the normal state would automatically pick that up and can adjust for that. Now translate that into emotion. So absolutely. And that's why in many trials, they say, oh, depression is the number one cause of this, or is the number one result of this. But I am sure that it can be backtracked and saying, well, why is it that patients don't have an awareness of the feelings? But if hyperglycemia and insulin resistance is affecting the autonomic nervous system, then you can believe that the ability to actually be aware of how you're feeling is affected as well.
So Dr. Michael, we're getting requests to scale you around the world right now. Harvey wants to know, how do I find a doctor to work with me in this way for diabetes? Because what everyone seems to do is they just want to keep throwing out the drugs,
That is a great question. And so, and this is an approach I take with myself. About 80% of what I do today, I didn't see in fellowship because we had to create new techniques and procedures. So I did travel around the world. But people say, well, how'd you learn how to do that? And my answer is, and it's not facetious, YouTube. There is plenty of educational material now, thanks to technology. Everything has a negative and a positive component. I don't look at it right or wrong. But the more touches we can have in the positive direction, the better. And so technology now has given us the ability to communicate and to self-educate in a way that's never been seen before. We can't expect our physicians to give us everything we need. That's also a little bit, anyway. So basically we can educate, I can give you resources. There are really good institutes that I would say I would put my stamp of approval on. I will email you those, Kim. So these have my official, and that's what I give my patients.
We can go ahead and put them on our website.
30-minute version in the office. And then I'll say, watch this video, and not just you, watch it with your family, watch it with your kids. When things are done as a team, when partners do things together, whether it's diet modification, whether it's quitting smoking, whether it's reducing alcohol intake, that's including the psychosocial component into the approach, and the success just skyrockets from there.
And Michelle is on making everyone jealous because she gets to go to you, and most everyone on here cannot. We love Michelle. You've done such a great job with her. But any red flags when people are going online? There are so many different resources out there. Yes, you're going to be providing your trusted resources, but as people are going out online and Googling.
Yeah, the red flags are going to be somebody trying to sell you something. Period. If there's a source of information that is just there to teach you, right? And it's not but wait, there's more, or, here's my supplement line, or here's my product. That's a good place to start. It doesn't mean that there aren't great people out there that are sponsored or supporting certain products, but I think something that is not tied to marketing or sales. That's a good start.
enough said on that. I agree with you 100%. That is the number one red flag. And we have Kay that actually has a question for you. Kay, go ahead and unmute. This will be our final question for Dr. Michael.
Yeah, it's just you talking about diabetes mellitus being part of the cardiovascular circle. It's actually an autoimmune disease. So where does it actually fit in? Because the autoimmune affects the liver, it causes the fatty liver to actually occur. So where does it fit in as an autoimmune disease in your treatment of it?
That's a great question. So if you think of autoimmune disease and then you think of acquired immunodeficiency, okay, what were the two populations that COVID targeted?
That'd be the pulmonary and the diabetics.
Obese and diabetics.
Obesity.
And if you combine those two, you have diabesity. So if you reverse engineer susceptibility to immune disease, right? Look at what that target is. If you were some evil genius and you wanted to hurt the world, and specifically the West, you would target those two populations, the obese and the diabetics, because of insulin resistance, which fuels the obesity, and obesity fuels the insulin resistance. What that does is it creates an immunologic dysregulation. So hyperglycosylation, or high sugar, lowers the immune status.
Yes.
So that vicious loop of high sugar, obesity, and then immune dysregulation, insulin resistance, it fuels that. So the only way to undo it is to increase insulin sensitivity and improve the immune system. And earlier in one of the talks was talking about nutrition. So we are what we eat. And the best prescription is what we put in our mouth. How can we be so narcissistic to expect that we can do whatever we want and expect the healthcare system to fix it with a pill or a prescription? It doesn't work that way. Yeah. So for thousands of years, all healing was based on at the base level, what we put in our mouth, and then acknowledging the psychosocial component to diseases, which is really stress.
So we're differentiating there between diabetes 1 and diabetes 2.
Yes, diabetes 1, right, as an autoimmune disease, right, they just get it. We don't really know why. There's many theories, like kids. That's the inability to produce insulin, which leads to death. Yeah. But then that's why I said type 2 diabetes, which has been around, but was in single digits.
It was, yes.
Single digits back in the day. We created this through human behavior.
Yes, an endemic.
Just like now, we have a pandemic of psychiatric and psychological diseases. We're not integrating the psychosocial component, right? We are disenfranchising the human being from reality, which creates a lot of psychological disease. And COVID unveiled that too. Anxiety and depression has never been seen at this rate ever, not even in wartime. In wartime, we were previously able to rally as countries. Now look at what a virus is able to do. It picks us apart. So it shows you how frail we've become psychologically. That also causes stress response. And that stress response translates into immune dysfunction. If we have an awareness of that, that's why I said behavior. And so if we have awareness of what is fueling these things, then we have a better shot at working together to correct these problems.
Thank you so much, Dr. Paul Michael. We really appreciate you. If people want to get in touch with you afterwards, where can they go?
So our office number is 561-500-LEGS. Feel free to give out my personal email address to the entire group. I'd be happy to forward that on. And our website is palmbeachheartvascular.com.
Everybody knows that smoking is a big problem when it comes to anything that's got to do with blockage formation, whether in PAD or any other vessel. So why? I'm just start with, it's always good to start with the why, because no one is safe from the ill effects of smoking. And if you go on the CDC website, they have testimonials from patients. This gentleman is 31 years old, Brandon. He lost both legs at the age of 18 from burgers. Now, burgers happens to be different than PAD. One situation where smoking leads to a very intense inflammation of the vessels, but that's one extreme that kind of illustrates that no one is immune from smoking, even the very young folks. And I've seen very young people below the age of 30 lose legs. Another example is another young man. Smoking is not only a problem itself, but it really makes other problems all that much worse. We all know diabetes is a big issue for PAD, but when you add smoking to diabetes, it becomes a very substantial problem for the patients and much harder blockage to treat. This unfortunate gentleman ended up passing at the age of 42. Had smoked since the age of 15. So that is really why we want to talk about this, because it's not just, well, what if, I lose my leg at the age of 100? It's not the end of the world. Well, no, it's not that. It really happens at a much younger age with smoking. So how exactly smoking, does the bad tricks it does on the body? It really does it through multiple things, and I'm going to summarize them here, but there's more to it than this one slide. So smoking lowers your good HDL, your good cholesterol, because the good cholesterol, the HDL, think of it as a sweeper. It runs through the bloodstream, picks up all the bad cholesterol from the vessel walls, takes it back to the liver to discard it. So the higher HDL you have, the better it is. Smoking impedes, lowers your HDL. It raises your triglycerides. That's another bad fat in your blood that raises, the chance of plaque formation. It makes the blood more sticky. It makes the blood more clot prone. It damages the cells that are lining the vessel wall, very, very important cells whose job is to prevent cholesterol and inflammatory cells from seeping into the vessel wall to create the blockage. When those cells get damaged, that's basically how the whole process of blockage gets started and continues to propagate, and increases the buildup of plaque within the vessel wall, eventually causing the vessel to shut down and cause issues. So a quick question to people here in the audience, every cigarette you smoke reduces your life expectancy by how long? And, I'd like people to kind of take a guess between the time between classes, the length of a Victorian speech, the average Instagram scroll session. You can tell that these questions are tailored more to the young folks who are following all those things. But then 3 songs by rappers. Let's start with Lil. The answer is it's actually 3 songs. It's every cigarette will reduce your life expectancy by 11 minutes. That's actually pretty astounding if you think about somebody smoking 2 packs a day. That's a lot of minutes reduce of their life expectancy every day. So which of these chemicals is not in tobacco smoke? And obviously I'm leading you down to option E here. These and many more are all available and present in tobacco smoke and in a lot of vaping as well. And there's actually more than 7,000 chemicals found in tobacco smoke, a little bit less in vaping, but all of them are very bad. And if you look back here, these are bad things here. Formaldehyde is very bad. Cadmium, that's what's in your battery. Acid, benzene, that's a main cause of bladder cancer, in addition to other harms on the vessel side. And this is a non-exhaustive, but a sample of all the things that are in nicotine. This is from the CDC. This is from the Surgeon General report dated 2014. I encourage people to look at it. Arsenic. I don't think any one of us wants arsenic in their mouth or their body. But guess what? That rat poison is also present in the cigarette smoke. So everybody talks about nicotine. I, as a cardiologist, I worry about nicotine, but honestly, of all those chemicals I just shared with you earlier, it's almost like nicotine worries me the least. And it's kind of a good idea for patients to understand, for smokers to understand how each cigarette peaks their nicotine level, at 40 minutes, but it stays in their system for about 120 minutes afterwards. And then what the nicotine replacements do and how they work and how much nicotine they give you. And again, as a cardiologist, I'm going to tell you, but also the cancer doctors would agree, nicotine is the least of our concern, even though it is a concern, okay? But it's all those other chemicals that lead to the damage of that, what we call the intima, the lining of the vessel. That's where the problem starts, okay? So tobacco kills 1,300 people every day in the US alone. These are real numbers. It used to be a much bigger number, by the way. So this is a lot better than it used to be, just because less people are smoking now, but still too many are smoking. Think of this as an illustration of what the vessel wall normally looks like, okay? It's really, think of it as a hose with 3 layers. The innermost layer is extremely thin, a single layer of cells called the intima, whose main job when it's healthy is to prevent anything from seeping inside the vessel wall and creating plaque. When that layer gets damaged by smoking or diabetes or the combination thereof, then you start to have cholesterol seeping within, and you end up with this occluded vessel, yellow here being the plaque, and eventually a clot on top of the plaque. This is kind of a cross-section of what a vessel illustration would how the vessel progresses from perfectly healthy to a horrible situation here. And another illustration in different ways, taken more like a long longitudinal cuts. This here is happening already to everybody in their age of 20 and 30 and 40. Plaques form. And when we are living in a healthy milieu, no smoking, no diabetes, those plaques regress. And then another plaque forms here and it regresses, okay? What happens is when we have diabetes, in this case, or smoking or both, the intima, that very, very minute layer, the pink layer on top of the plaque becomes, instead of being impermeable to cholesterol and to fats and to inflammatory cells, that intima gets impaired and allows those things to get inside that plaque. And now that plaque is not going to be resolving. It's going to progress, create a blockage. And then eventually that thin intima will rupture and clot will form and the vessel will occlude. And if it's a heart, it causes a heart attack. If it's a leg, it causes a acute cold leg or ulcer or whatever it may be. Another way of looking at it, again, that's kind of how this works. It's a gradual progression. And back here, or actually a little before there, it's still reversible if we do the right thing. As we get here, it's still stoppable, okay? Once we get here, we have to fix the vessel, but still do prevention to prevent the other plaques and other vessels that are still in this stage from progressing to here. So again, this is a cross section. This is the lumen of the vessel. This is the intima, single layers. This is healthy. That's what the vessel wall should look like. It's clean. There's no cholesterol in the middle. With smoking, with diabetes, with the combination thereof, with high cholesterol, these layers get harmed. And suddenly this layer that was lining the vessels was impermeable to the bad cholesterol, LDL, to the monocytes, which are inflammatory cells. Now is permeable, it's impaired. So the cholesterol gets into the vessel wall. And in the body, there's one rule. Everything should stay where God wanted it to be. When the cholesterol, which was supposed to be only in the bloodstream, seeps into the blood vessel wall, it creates an inflammation trying to get rid of it. And that inflammation keeps going on, creating, a lot of big words here, but cytokines are inflammatory markers, and, macrophages are another name for inflammatory cells. And little by little, that vessel wall that was normal here now is very huge plaque, complex, with a very thin wall, culprit to suddenly rupturing, creating a clot and occluding the vessel. And that's what invariably happens, okay? Now, the more we promote the health of the intima, that lining of the vessel, the more likely we are to prevent this progression to bad outcomes or retard it substantially. At the end of the day, as we get older, some processes are going to happen. Question here is, are we going to have this at the age of 95, or are we going to have it at the age of 20? And it's a choice in large part is ours. So these processes take years, accelerate in the later stages of development, and are reversible to a large extent, or at least controllable. Did I finish with that? So, and that's basically how you end up with blockages. And the issue with it also, God was very gracious in that, if you develop one blockage, many times there's collaterals around it. But in those patients that we're dealing with PAD and critical limb ischemia, blockage develops, and then another blockage develops distal to where the collateral would form, and then the third one develops. It becomes impossible, for the calf or the foot or the toe to have adequate blood flow, to have no pain, and to have full function. Now, on top of all that, there's also the cognitive part of smoking, which is a very addictive process by design. The cigarette is designed to be very addictive, not just with the nicotine, but also with the ammonia and other components within the cigarette, so that for a short bit, those who take a cigarette will have a short burst of a pleasure, of dopamine release, and then they're constantly seeking that pleasure. Well, guess what? It's not really pleasure, it's destruction downstream in the vessel wall, as we showed you. So it becomes a self-fulfilling prophecy until you break it. Strongly encourage people to look up this report. It's available on the CDC website. It's a very, very long report, a lot of big words in it. It's more tailored for doctors, but a lot of it has good language, even for lay people who are not medical background. And this kind of a summary of that report, it's not only the blockages, it's also the cancers, it's the chronic diseases, it's the reduced immunity, it's all sorts of things that are really at issue. And these are directly linked to smoking. And these are the diseases that are linked to even secondhand smoke exposure, not the minority of disease processes either. So the major conclusions then are, there's a substantial substantial concern here. This has been a long century of epidemic of cigarette smoking. We are far better now than we had been before, but there's still a lot of work to be done. And I am very concerned, and so many other doctors, that I'm very concerned, and so are many doctors, that the new wave of vaping is creating the next generation of smokers. So I'm hoping that we are going to be able to conquer that. I apologize for the noise. And this is kind of what you'll find in that report, how we really have been able with reducing, look at how those curves are going down over 100 years, and parallel that with how the smoking has also gone down. You can see how the curves kind of override. Again, further proof how important smoking is in all these epidemics. So in summary, smoking is addictive. Remember that vicious cycle. Cardiovascular harm comes from accelerating the process of plaque buildup inside vessel lumens. That process was already happening, but just smoking accelerates it. Smoking is especially harmful when coupled with other cardiovascular risk factors like diabetes, like high blood pressure, like family history and bad genetics, like bad cholesterol. On the positive side, the body reparative processes can reverse some of the harm if given the chance of smoke-free intervals. And that includes reducing your risk of stroke, heart attack, amputation, heart failure, sudden death, cancers, all of them can be at different intervals of quitting smoking, can be reversed back to almost, for some disease states, almost back to a baseline individual without smoking at 10 years.
I love where you talked about vaping, because we get asked that question all the time, where some of our pad warriors will say, hey, I gave up smoking, but I still vape. Is that harmful? That's question number one. And then number two is, well, I don't smoke cigarettes. Is smoking pot still harmful? And my answer to number two, and I'm curious if you agree with me, is the moment that you burn something, it becomes toxic. And the moment you breathe in that toxic air from whatever you burn, it's going to damage your arteries.
Absolutely. I agree with you 100% on both. So let's go with the second question first, because I've had a patient with burgers who was not a smoker, who only smoked pot. And definitely smoking pot can create the absolute worst, if you want to call it, of PAD, because that's a disease state that we really sit there, no matter how good we are, and our hands are tied, and we see very young folks get amputated. So absolutely, marijuana use is linked to burgers disease for sure. Now, going back to vaping, the problem we have, we have to be honest here. On vaping, we have less than 10 years of real history. With smoking, we have over 100 years. We've studied a lot more. We can be a lot more factual and a lot more assertive. So that said, if somebody is already a smoker and is going to use vaping as a bridge, a short-term bridge to get off the cigarette, the information we have now, even though it's not complete, because for smoking we have 100 years, for vaping we only have 10, So the information we have now is that maybe vaping is less harmful than smoking. So if somebody, I really talk to my patients at length about smoking every time. If somebody cannot, quote unquote, cannot quit, I say, okay, well, if you want to go into a bridge of vaping, assuming I don't have the proof for that it's less harm, I'm okay with it. But it's definitely not the discussion I have with somebody who started with vaping, who was not a smoker, because they're starting from zero harm, already taking some harm. Maybe it's less than smoking, but it's definitely not a no harm situation. Was that helpful?
Yes, it definitely is. And we also have a question about why is smoking following a revascularization even worse than prior to a revascularization? And one thing that I have heard in terms of answering that is that since the blood is sticky, it tends to stick to those areas that have increased inflammation, and where a procedure occurs or where treatment occurs, there is a little bit more inflammation, which could be why it tends to block back up quicker. Is that the case, or do you have another explanation?
What I would say, honestly, Kim, I don't know that I would say smoking is worse post revascularization than before. It's worse, period. Okay, I really don't know that we can say scientifically it's worse after the revascularization. It's just a horrible thing to have. But here's the deal: if you had pad that was bad enough to warrant a revascularization, okay, you are already at the tail end, and you're more likely to have even more harm from continuing to smoke, okay? Well, more accelerated harm. Everyone's gonna have just about the same harm. But, if you compare two people, somebody who only has a 50% blockage and somebody who has 100% multiple blockages requiring a revascularization, that second person is already further along that bad journey, if you want to call it that, of smoking. And they really they need to get their act together sort of faster than the person with a 50%, if I could put it this way. But smoking is going to be equally harmful every day. Every extra cigarette is equally additional harm to everybody. But when you're still younger and have had less harm, your body has a little bit more time window to repair, okay, on its own, with and without revasc. Whereas when you've advanced to where I or somebody like me needs to revascularize you, okay, you really need to wake up. You need to wake up and smell the roses. Additionally, even though we revascularize, let's say, your right femoral artery, and now your right foot is hunky-dory, happy, and you're healing your wound, well, your left leg probably has a 50 and 60 and 7% blockage that if you don't smoke, if it's going to stay like that, we might not need to fix it. But if you keep smoking, and same thing for your heart and brain vessel, if you keep smoking, those are going to be progressing, and you're going to come back, either with sudden cardiac death, where you don't come back, unfortunately, or with a stroke or heart attack or a contralateral leg amputation, God forbid.
Thank you so much, Dr. Khatib.
There's a lot of different things that can lead to the peripheral artery disease. And one of the things I do is I work with a lot of patients who have chronic kidney disease. And with the chronic kidney disease, I do an analogy with my patients. And what I tell them is that the kidney is what's going to be filtering out all of the end product from your metabolism. So everything that we eat is usually going to be filtered through either the kidney or the liver. So it's not 100% all going to go through the kidney, but there are some specific nutrients that do go through the kidney that need to be filtered out of the blood on a regular basis. And so what I tell people, the good analogy here is if you have a backyard pool, or any pool for that matter, and if it's filtering out everything from the pool's water is going to stay very clear, very, it's going to look great. You're going to want to be in it on a hot day. But let's say there's some leaves from a tree that are falling into the pool, and they start to clog that pump that's actually filtering out the pool. Or if the pump's just not working properly for whatever reason, eventually you're going to notice visibly a lot of change in that water. It's going to start getting dirtier. It's going to start looking murkier. Nobody's eventually going to want to get in that pool. So essentially, that's a good analogy for what our kidneys do. Our kidneys will be filtering out the end products from some of the metabolism of the foods that we're eating. So What happens is that when these nutrients start to build up and they're not being filtered out on a regular basis, it can lead to other diseases. So, this is where it starts to contribute to other diagnoses, such as the peripheral artery disease. So in addition to not having the kidneys properly filtering, there's a multitude of things that over time, if it's not addressed through the diet, and if it's a very severe stage of chronic kidney disease, like stage 4 and more into stage 5, you'll see a lot of the patients that will be going on to dialysis. If their body's just not filtering properly, then this is where it ultimately leads. But, in some cases, it's not 100% preventable to keep the disease from progressing. But the diet has such an important role in preventing the progression. And I have actually worked with a couple of patients where they have reduced their stage of kidney disease and gone from a 4 to a 3. So, but I'll be honest, it is one of the toughest therapeutic diets out there because there's so many foods that have to be monitored and kept in check with portion sizes. And it's, looking at labs pretty much every month. Unless they're stable, then sometimes the nephrologist will be okay with not looking at the labs for, like maybe another 3 months or so. But obviously that's usually that. I mean, this is all very individual between the patient and the physician. So, one of the things that, that we can do to help prevent that leading to the issue with peripheral artery disease, because peripheral artery disease is where the blood flow is just not flowing properly. And I want to take it a step even further back and say that a lot of times, again, not every situation or every case will be caused from this with the chronic kidney disease, but a lot of times it starts with diabetes. If they're not controlling the diabetes, then it starts leading into, again, that impediment of the blood flow and the building up of all of these other, in this case, it's the sugar, and then the sugar starts to lead to the breakdown of and having kidney disease and a multitude of other diagnoses as well. And then the kidney disease compounds into not having that blood flow into the extremities of the body. So, again, diet is really, really important here. But also movement. What I talk to a lot of the patients is I try to encourage them. A lot of them are, when I see them, a lot of them are in some pretty, dire situations with their chronic kidney disease because they may not have had anybody working with them leading up to a latter stage of chronic kidney disease. So even just sitting still, they can, march in a chair. They can use some canned goods to use to do arm lifts and things like that to help, just getting the blood flowing and helping that kidney. And, again, looking at the filtration rate with the kidney, that is the eGFR. So the lower that eGFR goes, the worse it is for this blood flow that's going through the body and it's not filtering out. And the main nutrients that we look at obviously are protein. The end product of the metabolism is going to be amino acids, and those are the ones that are going to be filtered through the kidney. So, watching the protein levels, whether it's coming from an animal source or even a non-animal source, we really want to make sure that they're not getting an overload of that. And something also, right now that's very popular is the keto diet. A lot of people who may be at a predisposition for diabetes as well as for chronic kidney disease may not even know it. And so if they're following a trend, a fad diet, with something like this, with keto, where it's high protein, and there's, they're going to see some weight loss because you're cutting out the carbs, and it is actually going to help with controlling blood sugars if they are diabetic. But over time, it could be potentially creating damage in the kidneys, which is then going to also lead to that impediment of the blood flow, which can lead to the peripheral artery disease, or actually contribute to it. It might not be necessarily the main contribution to peripheral artery disease, but it will contribute to it. So really wanting to contain that. And again, it's recommended about have 50 to maybe 60% of the protein sources coming from a non-animal source. Because a lot of times too, if patients are getting their main source of protein from animal sources, there are some natural acids that are in the protein, like the meats, that can also lead to other things such as gout. And so we want to try to keep that in control and have more of the protein sources coming from more of a non-animal source, like a plant protein. And one of the ones that they can use is something called quinoa. It's almost like a grain, but it does have a protein in it. So if someone's not diabetic, or even if they are diabetic, just keeping the portion control on that size of the serving to about a half a cup or less at a time. But it's a very good source of protein, a non-animal source of protein. And then pea protein, a lot of people are not familiar with this, but it's something that's been out for probably about the last 5 to 6 years. I actually go to a lot of the food conferences and have met with the food manufacturer, one of the largest manufacturers for pea protein, and it's just the green pea. It's a vegetable, but they will pulverize those peas into a powder, and that powder can be added into soups. It can be added into casseroles. You can even sprinkle it onto salads. So that's a way to get a protein, but get a protein from a non-animal source. So, but again, this is also, something that a patient would really want to be working with a dietitian, because once you start cutting out the animal sources, you're also cutting out your main source of iron. So a lot of chronic kidney disease patients will have low iron and will need to either have it supplemented because they just are not going to be able to eat enough of the foods that naturally contain it to get the amount to meet their essential needs for that. So that's one of the main things that we look at. Also, potassium is a huge component with the chronic kidney disease. And with that, the potassium is a big component in muscle contraction. So again, the patients are going to want to be watching their potassium as well. But if they have high potassium, over time, that can actually change the heart rate, and can be so severe if it's not caught over long term that it can actually lead to death, because it is changing the heart rate. So, watching the salt substitutes, a lot of the salt substitutes will replace that sodium with a potassium product. So that's one thing you want to really try to keep your eye on. And this is really good for anybody, really. You don't want to be getting a ton of potassium. And if you are working outside, or if you're exercising and in a very hot and humid environment, and you are a healthy, normal person in terms of not having any chronic kidney disease, you may need to replace the electrolytes, and that is one of the electrolytes. But for the chronic kidney disease patients, and I would definitely say keep that at a minimum, and make sure you're keeping your eye on that. And so another one of the nutritional components that are part of the chronic kidney disease is the phosphorus. And phosphorus is really important for strong bones, and it's in literally every cell of the body. It's part of the phospholipid membrane. So it's something also you're going to find in literally every single food. So this is not an easy nutrient to really reduce, because you're going to find it in a lot of, pretty much every food out there. But that being said, there are some foods that are naturally higher in phosphorus than others. So we just try to keep those products that are naturally higher contained to maybe about 3 times a week. Keep the portion sizes to about a half a cup or less when you are eating them. And then again, it's important that these patients, continue to get their lab work so that, the doctor and any dietitian that they're working with can help them make the appropriate modifications so that we're keeping this all in check. And then sodium is also a big component as well with the diet. So sodium can cause fluid retention, which again, if that's another one of those nutritional components that is also regulated with the kidney filtration. So it can lead to water retention, and over time that can also lead to fluid buildup around the heart, which can lead to congestive heart failure. So we would want to kind of keep the sodium in check as well. So to about 2,000 milligrams on the sodium and the potassium, both or less a day, is typically what I recommend for the patients who are around CKD stage 3 or less. Anything above that, we really kind of have to be a little more restrictive. So it's kind of in a nutshell, the components of the chronic kidney disease diet. Obviously, there's a lot more to it than what I would have time to go through on this segment, but this is how it all leads to, other diagnoses. So, if a patient is controlling the chronic kidney disease and they're getting some movement every day, and I usually try to tell people, especially the ones that have, they might be obese or they've never really moved, and now they have a lot, people feel bad when their values are out of the normal range. So a lot of times they're not feeling like getting up and just going for a walk around the block, or even trying to move around, even in their home, if it's, too hot outside. So even just any movement they can do is going to help that blood flow, so it's not pooling at the bottom of their feet, and then causing other damage down the road. It really goes hand in hand, and we do, and I personally as well try to look at the whole patient. It's we can't just isolate one area of the therapy. It really all works together. And if something's not being incorporated in to their routine on a regular basis, it can over time lead to, other diagnoses such as the peripheral artery disease. But really, this is something that, we really try to work with these patients and on a very personal, individualized basis. But these are the overall components for the diet for the chronic kidney disease.
We're going to be talking bloods, but it's not me that's going to be talking. I'm going to introduce you to Peggy Daly. Peggy, it's lovely to see you.
Thank you, Kay. It's a pleasure to be here too.
Peggy, could you introduce yourself and your role and what exactly you do?
Sure, exactly. I'm a naturopathic doctor and I live in the States. I'm also a nurse practitioner, and I'm one of the medical science liaisons at Boston Heart Diagnostics. I also have a private practice where I see patients primarily with cardiometabolic diseases, a lot of autoimmune, thyroid things, those kind of disease processes.
And you happen to know a lot about blood tests.
Oh, we try. Yes.
So could you tell me about Frontline? What would be the most important blood tests that you would ask our patients to have done?
Oh, for peripheral vascular disease. Kay, there's so many of them. It's going to be hard to touch on all of them today. But, some of the ones that I think are really important are things that really look at the lipids and the quality of the lipids. It's not just getting an LDL and a triglyceride and HDL. We need to dig deeper. And some of those things that I would categorize in the lipid bucket, if you would, are particles. And I know most of those viewing today are patients, but I think you can still grasp all this. And when you have bad particles, we can kind of call them bad particles that set up that disease in the vessel lining that creates plaque and then later your vascular disease. We need to know about those particles. So we need to know how many there are, and then the quality. Are they large or are they small? And we can offer that at Boston Heart to tell you about the ApoB. That will tell you about all the particles that are causing problems in the vascular system. And then those small, dense LDLs, the SD-LDLs, those are like those little BBs that get into the vessel lining and start recruiting all those other factors that come into forming plaque that causes the vascular disease. So we do have a really great way of assessing that at Boston. There's other things in that lipid bucket. One of the other things that comes to mind is Lp(a), and you've probably read about that or heard about that before, and it's genetically influenced. So you get some genetic things from your parents on both sides of the family, and you can have that elevated in your body. What that means is when it's elevated, it causes additional risk. You can have normal LDL, but you have that Lp(a) elevation, and it causes more risk than the LDL does. So when you have that, it's really important that your doctor evaluates that because it brings very specific risk to you. It causes increased vascular risk, which we know about. So you have to get everything else just perfect when you have Lp(a) in terms of vascular risk. And it also causes calcification or a buildup of calcium on one of the very important valves in the heart, the aortic valve, which is a really high pressure valve. And that one we really, really want to protect, as we do all valves, but it's a really important one to assess. The doctor can assess that by doing an echo on your heart, by listening with a stethoscope. So it's really important that that assessment be done as well when you have that Lp(a). And then there's also clotting risk. Now that is controversial right now. There was a new paper that came out about a month ago now suggesting that, no, maybe it doesn't cause that much clotting risk. I still see that in patients. So I think that's a bigger issue that we're going to need to do some more trials and some more data research on. But right now we're still saying, yes, it does cause increased clotting. And so we need to assess all those other clotting things in patients that cause vascular issues. So thinking about some of the genetics, you've heard factor 5, factor 2, MTHFR, all those other things that we need to think about for clotting risk. So we assess that as well for patients. So just some of those things in that lipid bucket. And then there's other buckets that we look at. I'm sure, Kay, you talk about diabetes, right, with all your patients? Yes, and that's something that Boston can really dig deep into. We have really a wonderful panel for diabetes markers. And that really is important, knowing about your status for your blood sugar and your insulin. Not just the blood sugar if you prick your finger at home and you know, oh, it's 100 or 70 or whatever, but what happens over the long period? So we have measurements that you can tell about what's going on over the past 3 months, what's your average, and that's a hemoglobin A1C. Then we have something called a glycated serum protein that will tell you what's your average blood sugar for the last 2 to 3 weeks. And we have ways to assess your risk of progression to diabetes. If you're not there now, where are you? And so we have some things that look at insulin levels because that's so important. You can have normal glucose, but your insulin can be sky high. And that insulin causes so much vascular damage. And people don't even know because nobody looks at it. And that's why we just plead with doctors, please do a deeper dive. We need to know. We need to know all that. So I'm sure you talk about that all the time as well.
We do. I mean, it's like shards of glass going down through your arteries, and it's definitely something. I mean, 3 in 5 diabetics will have peripheral vascular disease. Yes,
exactly. So it's a big factor.
It is definitely a big factor. And of course, there's other things that we have to take into consideration, like kidney failure. Is there tests that you offer for that one as well?
Yes, we have something that I really love. It's called a cystatin C. And it's a test that picks up kidney issues in the early stages, because most of the time, by the time the doctor literally stumbles into the fact that they're having problems, they're way in stage, at the end of stage 3 or 4 before they discover it through the routine labs, like a BUN and creatinine, and you'll get that in most chemistry panels. Doctors will see that. But those are things that are, you know, kind of near the end. And we want to find things in the beginning so we can deal with it. And there's such a correlation between vascular disease and renal disease.
Yes.
And so we need to pick that up. We always have to be looking for that. So we have a test that you can find that earlier. And that's why I love Boston Heart. I love working for them because I love using these tests because I can find things that I never could before and help patients and prevent some of the disasters that are normally ahead if we don't act on it.
Yeah.
So it's really good.
And if I was to go to my GP, my family doctor, how would I convince my family doctor to actually sign up with yourself and allow me to have these tests done? Is there a number he can call so that he can actually be able to join up with you and be able to offer these tests?
Oh, absolutely. We have different reps around the United States, and those reps will go to their office and help them, you know, look at what we have to offer and help them put panels together for their patients and sign them up. But to get to those reps, the doctor would just call one number, our customer service number, and I can give that to you. It's a 1-888-799-8711. And once they make that initial call and talk to the customer care team, who are wonderful people, the customer care team will reach out to the rep and say, Dr. So-and-so would like to know more about Boston Heart testing for their patients. And then the rep will reach out usually within that day or the next day and start them on a process to get signed up. And it's a small process. They just need to fill out a little bit of paperwork, which the rep can actually do 90% of it for them. And then they're on their way. And then once they do their testing on their patients, they can always call. There are two of us, Ann Sims and then myself, Peg Daly, and we're the medical science liaisons with Boston. And so they can call and ask for a consult. And then we can help them interpret some of the labs that have been drawn and help them learn if they need additional testing. We can kind of say, but this test relates to this one, and we really need to find out this piece of the puzzle, because it's like putting all these puzzle pieces together to help people in the most effective way. Yeah. So
could you just repeat that number, Peggy? Because it's so important that our patients know that number.
Absolutely. 888-799-8711.
Wonderful. That is absolutely wonderful. Peggy, thank you so much for talking to me today. And I wish you all the best. And hopefully all our patients will go and start nagging the doctor to dial that number. Thank you so much.